Okay, yeah. So Dr. Metz asked me to talk about, thoracolumbar injuries, and so as always, feel free to stop and we'll make our way through this. And if we have time, we can touch upon some cervical injuries if you guys want. So we'll just start off by talking about just the initial assessment for these patients, the functional anatomy. A few slides on imaging, but we won't stay too long on that. But we'll really spend the bulk of our time on, just stable versus unstable injuries, and sort of what we do from a surgical standpoint for these. And so in general, we divided the spine into 4 areas based on their, different anatomic considerations. And today we'll just focus on the thoracolumbar spine. And y'all have heard me say this multiple times that patients come in and they think that spine surgery is pretty complicated, but again, we typically, when it comes to trauma, we do one of 2 things. We decompress something that's compressed, or we stabilize something that's unstable. And if we just sort of stick with those 2 broad themes, like, it will sort of dictate the number of levels that we do and why we do those. And in terms of stability, I think it's always worth mentioning the classic White and Punjabi definition, which we're referring to instability as the loss of the ability of the spine under physiologic loads to maintain its patterns of displacement, so that there's no additional neurologic deficit, major deformity, or incapacitating pain. And then all these patients are coming in as through usually through the ED, and the reason I included this slide is something you all know, but we had a patient last week who was in activated trauma that the ED who didn't and they had neck pain, and the ED didn't work up with a CT head and a CT neck, and it's always sort of worth reminding them that this is sort of something that they need to be doing. In terms of, and this is the obligatory slide regarding history and physical, the important things are the mechanism, whether or not people are on anticoagulation, because if we see a deficit and their bony injury looks pretty minimal, then we could still we might need to be concerned about an epidural hematoma. And then the presence of any numbness or weakness. And in terms of physical exam, we have the main things are the motor and sensory exam, the rectal exam. And in terms of muscle strength grading, all of you know this, but I won't include this for the new interns, but we rate things between 1 through 5. It's not really a subjective. These have specific meanings. The cutoff is really if you think of 3 as anti-gravity, 5 is normal, and 0 is flaccid, then you could figure out the other ones in between. When it comes to the thoracolumbar spine, or the spine in general, there are multiple incomplete spinal cord injury patterns. The ones that tend to be most relevant in the thoracolumbar spine are really a conus level compression or cauda equina syndrome. And these look pretty similar. In terms of, so an injury at the level of the conus, which varies from person to person, but usually between T11 and L1 or L2. Sort of presents very similarly to cauda equina, where people may have bowel and bladder areflexia, lower limb paralysis. In the long term, if people have these for a long time, they can have a mixed lower motor neuron versus upper motor neuron sort of appearance. Whereas for cauda equina, where it's at the nerve roots, those are typically those people go on to really present with lower motor neuron deficits in the long term. And then in addition to identification of the initial fractures, a lot of these patients will have multiple injuries. So in the presence of thoracolumbar trauma, about 20% of patients will have a pulmonary injury. Similar amount will have intra-abdominal injury. The cases the case series sort of differ, but between 6 and 15% of patients with one spine injury will have a non-contiguous injury somewhere else. And so it's at least worth, I usually go through the, see if get some sort of imaging for the rest of the spine, and whether it's X-ray or CT really depends on how reliable the patient is in terms of their exam. and what their mechanism is. A lot of times we already have the majority of the spine image. The people with activated traumas will have, the CT, chest, abdomen, pelvis, and the head CT, and that's sufficient. And then a few words on imaging. These are the three modalities that we use in the PD. And then, so usually most people, if they have suspected spine trauma, the CT is sort of what we get initially. It could be high sensitivity for bony injuries. And then in terms of the MRI, these are, a lot of places, and I think our neurosurgery colleagues usually, tend to get MRIs for a lot of things. But for me, it's the two times I get an MRI. One is if there's a deficit, if there's a neurologic deficit, or if for some reason I have a high suspicion for a posterior ligamentous injury and I don't want to do uprights initially, where I'm concerned about, so if I have a high suspicion, we'll get MRIs for those folks. In terms of X-rays, we sort of glossed over this at the beginning, but these are quite useful in some scenarios. As we discuss fracture patterns, there are some where we think that they're likely stable. However, like CT is a supine study, and so we'll frequently obtain upright images to assess for displacement when compare those to the supine imaging. And this goes back to our definition of stability as the ability to withstand physiologic load. Sometimes, and then when I talk to our neurosurgery colleagues, they're like, well, why don't you just get an MRI to assess for the PLC? But even the people who sort of, Baccaro's group, who sort of put together the TLIX classification, of which assessment of the PLC is like a critical portion, they went on to show that MRI is, its sensitivity and specificity for like a PLC injury is actually pretty low. And so for me, the uprights tend to be a lot more informative than MRI sometimes. Okay, so we'll start talking about like sort of bony injuries. There's no, there's no universally accepted classification system. Historically, people started with sort of this two-column approach, which I think has a lot of value, just the front of the spine and the back of the spine. And then eventually that sort of evolved into this three-column model that really has persisted until today. And what that sort of added was sort of the middle column that we'll talk about, and that helps us really frame how we think of, differentiate between compression fractures and burst fractures. And then because of sort of all of these different classifications, and there is no universal one, a couple of years ago, the AOSpine put together its thoracolumbar classification system, where they divide things into type A, type B, and type C injuries. And so I'll start off talking about the three-column one, and then we'll sort of talk about the AO classification. So in terms of the three-column classification system put together by Dennis, you have the anterior, the middle, and the posterior column. The anterior is really the anterior 2/3 of the vertebral body. The middle is, from the posterior 1/3 of the vertebral body through the canal, and then the posterior is, encompasses the posterior longitudinal ligament, set capsules, and the inner spinous ligament. And if we just think about it simply, and this really goes back to our two-column approach, the anterior vertebral body here, its main job is to withstand an axial load. And then the posterior ligamentous complex, is really the tension band that resists forward flexion. And so if we think of these like blue squares as, our vertebral bodies with, here, this is ventral and this is dorsal. And, the PLC is sort of tension band posteriorly. Our center of gravity in the body is anterior to the vertebral body. So it's, similar to the olecranon or anywhere else where we consider a tension band. It's an eccentrically loaded sort of biomechanical structure. And so if both the vertebral body anteriorly is intact and the tension band's intact, it's gonna remain stable. And the issue, and so in injuries where that PLC is injured, so going forward, we're thinking about like our chance fractures. If we, we would, our spine would be unstable because we've lost that ability to withstand that eccentric load. And then in terms of like our compression or our burst fractures, what really determines stability is how well the anterior part of the spine is able to resist that axial load. And so, so you can, with a load, you can collapse anteriorly, even if the PLC is intact. Okay. And so, in the thoracolumbar spine, when we're thinking about instability, we usually think about, we're framing it in terms of like, failure of the anterior column or failure of, the posterior ligamentous complex. And then the way that we classify patterns is to really fit that, or thoracolumbar injuries, is to fit them into interviews. Okay, and in terms of fracture distribution, the majority of fractures occur between T10 and L2 at the thoracolumbar junction, where you have the stiff thoracic spine above, which is stabilized by the rib cage and the sternum at the junction of the more mobile lumbar spine. And these account, these T11 to L1 injuries account for the majority of thoracolumbar fractures. Okay. So the AOSpine Thoracolumbar classification, they sort of divide it into like A, B, and C, and try to make it similar to like the OTA classification. But I think just calling it A, B, and C is as close as they get. It's really where the similarities end. But if you think about it, they still try to make it the same way. Like A's are, the C's are the really bad ones. And, what they did is the axial loading injuries are the A types. The ones that have some sort of distraction are the B types, and the C types are the fracture dislocations. And this looks, this is the image that they had for the classification system. It seems sort of busy, but really it's sort of 9 different groups, but we can really, simplify this a fair amount. So we'll start with the C types, the really bad ones. And these are ones where there's some sort of translation. So these are 3-column injuries where there's either rotatory, there's some translation, whether in the coronal plane or the sagittal plane. Because, these are, these can be, there are so many different patterns. We just group all of these as, our C-type injuries. The most important thing is with these are high energy mechanisms. There's a high incidence of neurologic deficits with these. And because these are really unstable, they typically require long segment fixation. And so, this is a patient who came in a couple months ago. And so you can see on the sagittal, unlike the first sagittal layer, there is a translation component. On the axials, if you scroll through, there was also like a rotatory component. In terms of the MRI, there's a lot of times the dura is disrupted. You might have incarcerated nerve roots. And so when we open this guy up, we had a pretty large traumatic dural tear that we subsequently repaired. And these again are, because they're highly unstable fractures, that typically a lot of times will span more than one level. These are usually long constructs to require fixation. And so even in the case if someone had a complete injury, a complete neurologic injury, a complete cord injury, let's say even the MRI shows a cord transection. Initially, like I remember going through training, I'd be like, well, why are we even fixing these? If someone has, something like a neurologic injury that we know is not recoverable, but really the stability becomes important for like the patient's subsequent nursing care, and moving them in bed and bathing and all of that. And so again, the C-type injuries, disruption of all 3 columns with this with translation, high incidence of neurologic deficits. These are all operative and typically have long segment fixation. And then so we'll work our way to the other end, so the A-type injuries. So these are the axial loading injuries, and the 2 main groups are our compression fractures and our burst fractures. And the difference, is that the burst fractures extend posteriorly into the posterior wall. They extend all the way back. So as long as there's a crack here, I'm calling it a burst. I don't care if there's retropulsion, like a lot of retropulsion or very little. For me, it's just easier just to, that's sort of the binary in terms of dividing up a compression fracture versus a burst fracture. And so both of these can potentially be treated non-operatively. And it really just depends on the resulting stability or the resulting ability of the anterior vertebral body to resist the axial load that we talked about. I typically get uprights to make sure that we're not missing an occult posterior ligamentous injury. Sometimes you can see sort of chance type fractures where it's compressed in the front and it can be distracted posteriorly. And so, you know, for these are people I typically get, or I always get upright x-rays for, just to make sure that we're not missing a PLC injury. And yeah, and so here these really comprise, you know, take up the bulk of this, you know, classification, you know, of this classification slide. And so the A1s and the A2s, these are our compression fractures. Can you guys see the cursor here or no? Yeah, okay. Yeah. So the A1s and the A2s, these are our compression fractures. The only difference is the A1s involve one end plate, the A2s involve two end plates. Over here, in the picture here, they show a picture of a unique type of one of the A2s where it's just a straight split down the middle. You know, you'll commonly have people refer to that as like a pincher type. You know, most of the compression fractures that we see that span two end plates, it's really comminuted, similar to like this burst fracture, except it doesn't go down to, you know, posteriorly. But sort of a side note, when you do see like this sort of pincher types, these are predisposed to potentially spitting this anterior, you know, this anterior one out on follow-up. So those are, you know, a subset of these compression fractures that I'll actually follow quite a bit more closely. But in general, the A2s are any compression fracture that spans two end plates. And then the A3s and the A4s are really the bursts, again, one end plate versus two end plates. And really you know, yeah, but we treat them both the same. In terms of burst fractures, you know, they have varying, you know, that fracture extends into the posterior wall of the vertebral body. And, you know, our radiologists love representing the actual percent of, you know, how much occlusion of the canal the retropulsion occupies. But for me, what's a lot more important than this is the patient's neurologic exam. And so, but, you know, whether someone has a lot of retropulsion or a little retropulsion, as long as they have a neurologic deficit, that's really what guides my treatment. And we'll talk about how that plays into treatment when we get into the TLEX classification. And so again, so going back to this sort of simplified model, you know, a compression fracture, we just think of it as like the anterior 2/3. You know, you could imagine that, you know, we could potentially still be stable with, you know, even if we're compressed through the anterior portion here. When it comes to the burst fractures, it really depends on how competent this posterior wall is. Like if it's not too if it's not too comminuted, then the bursts are typically stable. If it's super comminuted, then they tend to be unstable and they collapse. In kyphosis. Historically, like when pedicle screws were first sort of developed or introduced and used widely in the early 1990s, you know, people tried to treat a lot of these bursts with, you know, short segment fixation, so one above, one below. But you can imagine if, you know, if you have an unstable burst and it's sort of very comminuted, those top screws are, you know, doing a lot of work. You're essentially spanning an area of comminution with just one point of fixation above and below. And so, you know, your screws can potentially cut out if you're just trying to do, you know, short segment fixation. In the mid-90s, McCormack started put together this load sharing classification to predict who would fail with just posterior short segment fixation for these burst fractures. And what it really amounts to is just something that's pretty intuitive. Is the greater amount of comminution, the more likely that just a one above, one below, like for an unstable burst fracture, the more likely that just one above, one below will fail. And so this is a scoring system. But the main, you don't need to quite know the specifics of it, just know that the amount of combination sort of predicts whether or not a short segment fixation will work. And so with this, so for most unstable burst fractures, if we're doing all posterior fixation, we typically do 2 above and 2 below posteriorly. And it's similar to, like, you know, you think about it, it's like a bridge plating construct for accommodated long bone fractures. So the problem is this is problematic. So if someone comes in with an L3 burst, especially if it's a young person, 2 above, 2 below, you know, would be an L1 to L5 fusion, which, you know, carries a fair amount of morbidity. And so in some, you know, and so people have more tried to go back to this, you know, short segment fixation or to amend the way that we do it. So another option, if people are feeling, you know, because of a failure of the anterior column, is to just reconstruct the anterior column with a cage, you know. And so if we're able to get the anterior support with a cage, then, you know, you can do short segment fixation, 1 above and 1 below. This requires like a second approach. So for unstable burst fractures, you know, the 2 treatment sort of options that you'll typically see if someone's unstable is an all posterior, 2 above, 2 below, or what we call short segment fixation. For me, this is usually a conversation with the patients. The big factors that factor in are, you know, the fracture location. So like an L3 fracture, as we talked about, I'd be a lot more likely to try to push for short segment fixation. The downside with the short segment is it's a lot more invasive. It's usually 2 approaches, like a posterior approach and a lateral approach, both of which are tolerated well. And you can potentially do the posterior with just a, you know, with both of these, you could do them percutaneously, posteriorly. But it's usually a conversation with the patient, you know. But if, you know, if the burst is up to L, you know, if it's like a T12 burst, then, you know, the difference in terms of the mobile segments, whether we do short segment or long segment, is very minimal. We're either going down to L1 or to L2. And so, again, you know, it's patient factors, what their activity level is, what they're hoping to get back to, as well as the fracture location that really determines which one of these we pursue. In terms of, you know, more so for the seniors, in terms of positioning these patients, so for these bursts, we're putting these folks onto like a, you know, onto a Jackson frame to really get our 3-point mold and to try to get that ligamental taxis, you know. And so the body weight sort of pushes down, and we have, you know, bolsters underneath the chest and the ASIS. The majority of these injuries are at the thoracolumbar junction. So it's, again, a 3-point mold, just like a distal radius. And yeah, and so that really encompasses, yeah, so those are our axial loading injuries, so A1s or A2s or A3s and A4s. These A0s are just something that they included for, you know, isolated spinous process fractures or TP fractures, you know, just for completeness sake. And so those are things that, unfortunately, that, you know, the ED consults us for, even though I don't think that they need to. Yeah. So any questions about sort of the compression fractures or the bursts?
I had a question, Dr. Naga. I've seen like some studies talk about short segment fixation with like small screws in the unstable segment.
Yeah.
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 Have you seen that, or have you had experience with that?
Yeah. And so with when you put in short screws, it definitely adds to the stability of the construct. And you can let me go back here. Yeah, and you can see a lot, you know, you can imagine that, you know, for these burst fractures, a lot of times these pedicles are also, you know, they are diastase, and so it helps capture those. And so if I'm doing a posterior, like the 2 above, 2 below, I will still try to instrument these. Even if I'm doing a short segment, I will try to put short screws here, especially on the right side. Because if I'm coming in with a lateral corpectomy, I usually do that from the left side. And so I have, you know, if I put in a screw on the right, it's not going to interfere with the placement of my cage. You just don't want to, if you're thinking about potentially, you know, going back in for, you know, placing a cage, you just don't want whatever instrumentation you put in to interfere with that. But in terms of instrumenting the injured segment, it definitely adds to the biomechanical stability, whether you're doing long segment or short segment.
Cool, thanks.
Okay. And so we'll go back. Yeah. So to our B-type injuries. So really, these are these are the B1s and the B2s, and these are both our chance type fractures, and so these are flexion distraction injuries. So we typically think as the anterior columns, it still, it's fractured in a way where it can still resist an axial load. You can see here, like this example for this chance fracture is like just a transverse fracture through the anterior body that's not comminuted, but you disrupt the PLC posteriorly. And yeah, again, this is classically described by Chance in 1948, after like the increasing use of lap belt mechanisms in cars. And with that, people would get into accidents and have sudden flexion over an anterior fulcrum. And this has like a high association with abdominal injuries, namely small bowel injuries. And so, yeah, and again, yeah, these represent a disruption of the ability to withstand forward flexion. Because for these fractures, all we really need to do, like from an operative standpoint, is to reconstruct the posterior tension band. And so, as long as the anterior vertebral body is not comminuted and sort of have this hinge here, you're just reconstructing that tension band. It's just like an olecranon fracture. And so, yeah, so one above, one below is sufficient for these. But they do differentiate between these, the B1s and B2s. The B1s are sort of the classic chance fracture, where it's a transverse fracture through the anterior vertebral body, through bilateral pedicles, and through the spinous process. Here, this is, technically, the way it's described is an all bony injury. But most of the chance type fractures that we see are not like this. Most of them have, some disruption of the discs or some comminution, or the exit posteriorly through, the injury exits posteriorly through the PLC. They differentiate this because, with this fracture, let's say you do come across it, you could potentially, you can rely on the bone-to-bone healing. And so you could potentially put someone in a hyperextension brace, so like a Jewett brace, and treat them non-operatively. But these are so incredibly rare that the group that put together the classification, like through all their the multiple sites, they weren't able to find like a CT slice that was a pure, example of this, where it's transverse to the anterior vertebral body, the pedicles, and the spinous processes. And so the majority of the ones that we see are, fall into this B2 category, but we typically treat them the same. Okay, and these B3s, these are also, they have and so these are the hyperextension fractures where, you have disruption of the ALL. And these are really fractures that are exclusively seen in patients with, some ankylosed disorders. So whether ankylosed spondylitis or DISH. And so, and these are, a unique subset of patients that's worth spending a little bit of time on, because they're, they're at risk for, a pretty significant neurologic injury. And so, these are patients where they have typically autofused for, across multiple segments. And the problem is when they have a fracture, even if it's non-displaced, all of that motion that they see happens through that one level. And so you don't have like the other levels to sort of take some of that motion. And so these are patients where these are essentially, we always describe them as long bone fractures of the spine. And so, again, AOSpine and DISH, well, they just have different, appearances. With DISH, you have these flowing, these thicker osteophytes, but functionally they're the same, even though their underlying sort of cellular mechanisms may be different. And so for these patients, so even patients with, if their fractures are non-displaced, they are at risk for, if they displace it, it's potentially catastrophic. And so if you see a patient with, AOSpine and were consulted for neck or back pain, you just need to think of them as having a fracture until proven otherwise. to the point where even if I don't see, if they're endorsing pain and I don't see a fracture on CT, I will obtain an MRI as long as they can fit in the MRI scanner. These patients, unfortunately, with people with advanced AOSpine, they may have, these significant kyphotic deformities. And so a subset of them won't, the key is not to try to force them into the MRI scanner because there are several case reports across, from, several, big reputable trauma centers where people have tried to force them into a scanner and caused, displaced and non-displaced fracture, and people come up paraplegic. So, and this is an example from my fellowship with patients. You can see how this, fracture can be easily missed. This was done at an outside hospital, and the patient subsequently, came back. And this isn't much displacement, but it was enough to cause an incomplete port injury. With these patients, it's a game of millimeters. Because these are, essentially, if you think of it like a long bone, these patients we typically treat with long constructs. So just think of that, it's just near, far, far in terms of their fixation. Really these patients, like as long as I really don't, the reduction really doesn't make, as long as they remain neurologically intact, these are patients who you don't really need, it's not like a transverse fracture, we need cortical contact. These are patients who are trying to lay down bone actively, and so they're going to heal. And then these patients, because of their general kyphosis, these are ones I'll place, in terms of positioning in the OR, we'll place them on the Wilson frame. Because if we try to hyperextend these patients, there's a good chance that we will cause a cord injury, because then the posterior lamina will as you hyperextend them, it'll dig into where the cord is. These are patients that whenever we're fixing, we're placing onto a kyphosing bed. Yeah, so we've talked about, these are, this portion of the slide, these are our compression fractures again. These are reverse fractures. These are our transvariants. And then these are the hyperextension fractures that we see in spawn, and these are just the bad fractures that no one's going to miss. And so even though the slide seems busy, it's really, we're just grouping all these injuries into one of 5 different types of fractures. So is it a compression fracture or a burst, or a chance fracture, or the AOSpine population, or the really bad high energy traumas. And you can see how these chance type fractures, the bursts and the compression, some of them, like on their initial CT, may present similarly. And for me, the upright X-rays really help differentiate, like, is a fracture, which tells me which one of these are the fractures generally behaving as. And because on the uprights, you can either have collapse of the anterior vertebral body, or you can have distraction of the posterior ligamentous complex, and that's what really differentiates these. Yeah, so in terms of decision making, so we've sort of already talked about, and so in terms of the TLX classification, and so this is, it's not just like the bony pattern, and so we already alluded to like the TLX classification, where the decision to operate and what we do in the operation really factors in, takes 3 things into consideration. 1 is the fracture morphology, the actual, like the bony injury. 2 is the soft tissues, namely the posterior ligamentous complex, again, the interspinous ligament posteriorly, the spinous processes, the sac capsules, and the PLL. And then, the ligament flavum, and then their neurologic impairment. And the group that put together the TLX classification tried to like group these in a way, but I think, we've already sort of, with everything we've talked about, you come to like whatever decision the TLX classification is going to give you. But yeah, this is just it's a really good framework for sort of like the things that we think about. So in terms of morphology, these are, the points associated with, so if this is something I sort of find, so if there's no abnormality, why are we even looking at this classification? But I guess though, like someone with a compression fracture, so again, anterior 2/3, that's a 1, the burst fracture, it's a 2, the rotation translation of these. And the cutoff here is 4, and the way that they assign these points is so that you would reach the conclusion that you should, just by understanding the fracture pattern. Because if you have like a distraction injury, so these are chance fractures, or the hyperextension fractures were already at 4, and you couple with that they're going to have, by definition, a PLC injury, you're going to be above 4, and then the same holds true for the rotational translation. These are C-type injuries that are always going to be operative when you weigh in the other things that can go into with that. And for the PLC, so it's either intact or it's injured, or we don't know. And so, there are on the CT, there are definitely signs that it's injured. So if you have a transverse fracture that's distracted through the spinous process, if you have splaying of the spinous processes, then you can go ahead and say it's injured. Sometimes, and then on the MRI, sometimes there's edema posteriorly and you can be suspicious of it. And so there's just this big gray area. And I think this is really what makes this classification, this is really where the subjective nature of the classification sort of comes in. Because again, their group showed that, the sensitivity and specificity of MRI in determining whether or not there's a PLC injury is actually pretty poor when you compare that to what what you see when you open these patients and are looking directly at, the interspinous ligament. But again, I think the importance is just thinking about the ability of the spine to withstand, to resist that forward flexion. And then the neurologic status. And so you get 0 points if they're intact, 2 points if it's a radiculopathy. So this is something that we commonly see with our TEEPs, with our L1 bursts, where people may have some radiating pain to their hips. And you get 2 points for a complete cord injury, 3 points for an incomplete cord injury, and 3 points for cardiac equina. Their assignment of the 2 points for a complete cord injury, I think really goes to the initial nihilism surrounding complete cord injuries. But again, and this is something it's really hard to know whether, when someone first comes in, whether they have a complete cord injury or an incomplete cord injury, in the first couple of hours, because they just might be in spinal shock, and we're usually not waiting 48 hours to make a decision. And so at this point, but if someone if you're suspicious for a complete or incomplete cord injury and there's ongoing cord compression, those are people that we're going to take emergently to decompress. And so that's really, the TOX classification. And they sort of you sum all of those up. I think I lost that slide at some point. And you see whether it's more or less than 4. And the 4s are sort of your choice. And the classic, number that comes out to a 4 is a burst fracture where you get 2 points, and you either give them 2 points for a radiculopathy, or you give them 2 points for an indeterminate PLC injury. And in that case, it really is dealer's choice. And I think that's, for me, that's a conversation with the patient, in terms of what they want. In terms of, those are pretty much the majority of the prepared slides I had for the thoracolumbar fractures. Before sort of opening up the questions, I did want to mention this. So this is something, this is sort of like a frustrating thing that the ED is trying to push. The ED doesn't want to look at a sheet of paper to see whether we're on call or neurosurgery is on call. So they're really pushing for this spine virtual pager. And it's really a pager where for all their consults, they just put in this consult to this 1 pager number, and then it'll either get routed to ortho or neurosurgery, depending on who's on call schedule. The thing is, it's going to be on us to route those pages. And so I talked to the neurosurgery folks, and I think what's going to make, and this is, I'll let you know, I'll send an email out once this actually comes, happens. I just figured out this was a good thing because all the majority of the residents are there. And so whoever's coming off spine call, like Monday mornings, will, I think it's through one of the web pages, we'll just route the spine pages to the other service. And that way, if someone's, if we're still getting spine pages when we're not on call, it's sort of on us to, to have those routed to the neurosurgery. And then when we get called, if there's suspicion for a spinal cord injury, then we just need to ask the ED, when they talk to us and give the consult, we just need to ask the ED, the consult neurosurgery. They won't be doing it automatically, but, and that's something you guys can talk to me about too. So, yeah, so I think we have a bit more time. Yeah, and so any questions so far on like the thoracolumbar stuff?
Hey, Dr. Naga, just a logistics question. For that spine virtual pager, when is that? I'm not sure if you mentioned this. When is this beginning?
No, we're still working on like the actual getting it set up.
Okay.
Yeah, so I just wanted to just put it on.
Okay, perfect. Yeah, I think that'll be really helpful.
Yeah, yeah, I think it all. Yeah, and so we'll and then of course with anything, if there are any sort of hiccups here or there, like we'll just have to figure them out. But overall, like I think over the last year and a half, at least the neurosurgeons, between neurosurgery, I think everyone's really been happy with the care that you guys have all provided for these patients, and how well you guys take care of them, and all the communication between the different services. And again, I just wanted to thank you all, because I know prior to a year ago, it'd been a year or two before we were taking spine call, and so I really appreciate all of that. Yeah, so I think
that was a really nice overview of all the classification systems, the AO and the TLIX, and hearing your thought process is very helpful. I was curious in terms of, I'm on the PED service right now, and we're just wondering, I don't know, has there been any PED spine trauma that you've encountered? Do you think differently if the patient's skeletally mature in terms of operative indications? If a patient's sort of, let's say 15, 16, they are, although their PEDs are still skeletally mature, do you still apply these same principles to operative management?
Yeah. I think the principles still apply, and I would still think of the injuries in sort of the same way. What becomes trickier is just the implant uses when you get to people who are, to kids who are like really small, so like 4 or 5 year olds. I think you're sort of limited in terms of your screw options, but you can still usually get fixation. You might need to change your fixation strategies, go back, but in terms of the priorities are still the same. So if there's nerve or cord compression, and then the question is, those would be patients where I think about, well, is this a fracture that's going to heal? And like I'd be a little bit more critical of whether or not to fuse. And so, and that really just depends on how much bony healing you're going to achieve versus is there like a ligamentous injury that you don't expect to heal, which is sort of similar to how I like approach the chance type fractures. So even the majority of the ones these chance type fractures, I think like I try to think like, is it mostly bony or is it mostly ligamentous? And if it's mostly bony, then those would be ones I would consider like percutaneous fixation without a fusion. And if it's mostly ligamentous, I'd probably, even though we'll be short segment, I'll usually fuse those. So it's sort of a separate sort of tangent off of your question. But in terms of kids, the tricky thing with kids is the imaging becomes trickier, especially in the upper cervical spine, in terms of trying to find determine like what's a true injury versus like an apophysis. But the same thing sort of apply.
Awesome.
I also had a question. I also had a question about, I guess like 2 questions. So like timing of surgery, which I presume is, I know like all things being equal, we're at the general and we kind of get what we can when we can. But in terms of actual like educational purposes, and I presume it'll be different for decompression indications versus stabilizing indications. And then for the patients with spinal cord injuries or for decompressive indications. I guess this is more so when we call neurosurgery, of course, but like kind of timing of steroids and that kind of thought process as well.
Yeah. So I think we'll divide that. So if they're neurologically intact, for me, there's no urgency to stabilize, as long as, but for those patients, we're just reiterating to the nursing staff, whether they're thoracolumbar precautions or cervical precautions, whether we're talking about the C-spine or the TNL spine. Those are patients where, I sort of think about them as sort of like a damage control orthopedic standpoint, where those are patients where we have the luxury of trying to get them resuscitated appropriately, they're lactate corrected before we, stabilize them, as long as they're sort of behaviorally, like they'll be able to tolerate those precautions. There's a subset of, our patients of the general, there's a subset who will put themselves, at potentially harm if they themselves are not sort of adherent to those. And to those, like I'll try to push to do those earlier. In terms of neurologic decompression, the majority of the studies support like an earlier decompression, at less than 24 hours. The thing is that the general, if there's ongoing nerve compression or core compression with deficits, at the general, the neurosurgery groups, they're part of a multi-center study that's looking at like ultra early decompression, and so their goal is in less than 6 hours from injury, or 6 hours from presentation, which I think they must be doing it as like an intention to treat type thing, because at the general, it takes a couple hours to get the MRI. But once we get the MRI, the ORs are actually pretty good about getting us in pretty early. So in terms of the data, so if there's cord compression for spinal cord injury, the literature supports a 24-hour, 24 hours, doing the decompression within 24 hours. With more recent studies that are really being pushed out of the journal and their colleagues is earlier is even better. But then that's also subject to some, there's some conflating things with that, because we're probably treating a number of people who are in spinal shock, and so their outcomes seem to be better, like people who were considering Asia A's when they're actually Asia C's, but earlier is typically better. In terms of steroids, the data, so what it comes down to is people could be sued for either giving steroids or not giving steroids. And so I think what most people have sort of moved to are sort of institutional, protocols. But if you look at the data, I think there's a subset of patients where steroids are pretty useful. And what it shows is usually if you give steroids, you can usually preserve, you can potentially, like in a complete cord injury or an include, you can usually get one more level of function. So if you're a C5, you go down to a C6, that's pretty important, because someone can go from not necessarily being able to use a wheelchair to then being able to use a wheelchair. And so, but you can see like the utility of that would be pretty minimal if you're going from like T5 to T6, right? Where functionally, with just a little bit more sensation, there is a more, these are, in our high energy traumas, giving steroids earlier, it does have like a higher mortality, and there's like a higher, post-op like pneumonia and organ failure sort of component to it. And so in terms of older patients, you're sort of driven away from it. And so I think in general, like, with the neurosurgeons here, we don't give steroids, but let's say I was in a different practice, the patients I would consider steroids for would be young patients with a cervical level complete or incomplete injury. Those are sort of the ones where you sort of maximize the benefits and they're at less risk for the medical complications with early high-dose steroid, giving them early high-dose steroids. The other sort of population that steroids are sort of helpful in is people who are coming in with metastatic disease and sort of like a recent worsening of their symptoms. A lot of times the steroids can be a good temporizing measure, in that setting. But that's not the trauma setting.
Yeah, that's helpful.
Okay. Any other questions in terms of just spine call? any issues in terms of like working with the ED.
I mean, I don't think there's been any issues. I think one point that I think you brought up in the beginning that I was surprised about being at a trauma hospital and start taking spine calls. A lot of patients aren't given C-collars.
Yeah.
That's not even like thought about. So I had to try to bring it up, but I was a little surprised about that. But other than that, you know, that's no issue.
Yeah, I think any activated trauma is just being a cervical collar until they're cleared either clinically or radiographically. So.
What's the latest with the MRI, pacemaker MRI?
Oh, we should be able to, yeah, we should be able to get them. I actually got an email about it a couple of days ago. But yeah, so there's, yeah, I think Charlie were involved with that last one. That was sort of a disaster. It's still, I guess it looks like it's easy for us to get it during the day, but at night for our ED patients, it may be a little bit more difficult. So those are patients where we'll probably need to arrange for like an MRI early the next day, or, I mean, for those patients, I mean, and those are patients I'll be heavily involved with, you know, both talking to the neurosurgery colleagues, and then together we'll be putting pressure on the MRI folks, because that's, yeah, but we should be able to get MRIs in patients with pacemakers now. Really, the biggest issue, concern is the patient going to have like a cardiac event in the MRI scanner, and they need to have, you know, someone trained to watch their EKG while they're there. And so,